Hello, my name is Sasha Thimler, and today I am going to be doing a respiratory assessment. So what I'm going to do first of all is go to my patient. I'm going to walk into the room, wash my hands, introduce myself, and I'm going to ask them to state their last name and their date of birth. And I'm just going to be explaining that what I'm going to be doing today is a respiratory assessment. And we can kind of just go into a few things that I'm going to ask you a few questions first of all, and then ways that you can help me out is, well, we can go over the questions first of all, but then I'm going to have you take some deep, slow breaths for me when I'm getting to the point of listening to the lung and breath sounds. So to get started, I'd just like to, first of all, discuss a little bit of history. So, first of all, at this time, are you having any symptoms? Any shortness of breath? Any difficulty breathing? Any thing that I should be aware of as far as that goes? Then I want to know a little bit about their personal medical history. Have they been diagnosed with asthma, COPD, any respiratory issues that I should be aware of? And then I also want to know about their family history. Do they have anyone in their family that has any respiratory diseases, anything that could be significant as far as his health goes? So we also want to know a few things about his lifestyle and his personal life a bit. So we would ask questions like, do you exercise? What does your diet look like? We'd also want to ask if they currently smoke or if they've smoked in the past. We also want to ask questions like vaping is something that we'd want to touch base on. And then also their occupation. A lot of occupations can increase the risk of respiratory issues. So we'd want to make sure we have a good background of occupation or even hobbies that they do on their own time. We also want to discuss medications. We want to know whether a patient is possibly using oxygen. An inhaler would be something we would want to know. Even things like essential oils, anything that the patient uses, we should be discussing with them. So once we have a good history, I would then just ask the patient if I can go ahead and lift the shirt up and kind of inspect the thorax, the chest area. So with consent, I'm going to kind of lift this up here. All right. And first of all, I'm really just inspecting. I want to look at the patient's overall chest area. Is there anything abnormal that I'd be seeing? Does it look symmetrical? Are there any bumps, any bruises, anything that would be abnormal that I'd be looking at? There's a few other things that I can do is I can assess the patient's overall skin color. I want to see, are they diaphoretic? Are they sweating at all? You can look at their fingernails to look for clubbing to see if that's an indicator that they've been low on oxygen for a long time. You can look at their nostrils. Are their nostrils flaring at all? You can look at the accessory muscles. Are they using those accessory muscles to breathe? So there's a lot of different things, and looking at the skin and inspecting the skin is a very important thing as well. Now when we do a respiratory assessment, we're doing anteriorly and posteriorly as well. So we're kind of starting here in the front, and we'll do the inspection on the back as well. So everything looks to be good so far. So then I just kind of want to palpate. So I'm going to palpate the chest, and I'm going to be checking for two things. I'm going to be checking for excursion and tactile fremitus. And the classic word that you use while checking for tactile fremitus, Okay, sorry about that. Tactile fremitus. You want to be using the word 99. So what I'm going to be doing here is just kind of putting my hands on, and I'm feeling for vibrations. you would normally feel a vibration, and it can be increased or decreased, but we'd have the patient say 99, 99, 99, and then you would be turning the patient around as well, and you would be feeling posteriorly. And same thing, have the patient repeat 99, 99, 99. Now, while we're on the back here, you would inspect, and then you can also check for excursion. So this is where we put our hands lower on around the 10th intercostal space, and you're going to have the patient take a deep breath, and you're going to put your thumbs together here. So when the patient takes a deep breath, you would normally see your thumbs go apart about 1 to 2 centimeters, and then as they exhale, they'd come back. And that would be a normal finding that you would expect to see. So as we go on, kind of turn this around here. Okay, so as we go on, you inspect first, then you palpate, so next we're going to percuss. Now this is something that we don't always do, but what you would do is you're percussing to see if there's 4 different things. So resonance is going to be your normal finding, and that's what you would expect. Now, when you percuss, you kind of use your 2 hands here, and you're percussing with you're tapping with your other fingers here. Now, if it's hyperresonance, then that is considered overinflated. So you may see someone with asthma that may have hyperresonance. Other sounds would be the dull sound, and that could be that it's filled with fluid. Otherwise, it could sound flat, and that could be a tumor or something like that. So that's kind of what you're percussing to see, what you hear and what you feel. So you also want to osculate. We're going to be doing breath sounds as well as lung sounds. So when we go and listen to breath sounds, we're going to be hearing 3 different things. So you have your bronchovesicular, which is going to be higher up on the trachea, and that's kind of heard more up here in this area more. You're also going to hear bronchovesicular, and that's going to be more in the middle, and then that's also going to be posteriorly, that would be in the middle area here in between the scapula. Then you're also going to listen to vesicular, which is going to be your more normal on the outside areas here, as well as the outside areas here on the front. Another thing I want to note is that when you are listening, you would also listen on the side. So the left lung has 2 lobes, the right lung has 3 lobes. So you're going to be taking the patient's, or you're going to be listening to the patient's sounds on the sides as well. And what you'd have the patient do, my patient doesn't have arms, but you'd have the patient kind of lift their arm over, and then you're going to listen on the right side to four places, but on the left side you only need to do the 3 because of the lobe differences. So you just take your stethoscope here, and you're going to listen here, and this is when you have the patient take a deep breath in and back out. You're going to listen here, here, and then that extra one here. Same thing on the left side, just not the extra one. All right, so the other thing that we would be listening to is adventitious lung sounds. So you can hear multiple or a number of different sounds, but some of the ones that you would possibly hear would be like a wheezing, which is the narrowing of the airway. You may hear crackles, popping. To me, that's a popping sound, which could indicate that there's fluid. You might also hear a rhonchi, which is much lower sound, and that would be heard, that's almost like a continuous snoring sound is how I would describe it. You might also hear stridor, especially in children. That's a high pitched, and that's generally heard better over the throat area. And then you also could hear a pleural rub, which is kind of the friction of the two balloons rubbing together. So those would be abnormal lung sounds. So those would be things that you would need to be documenting as abnormal. Now, when we're listening, we are going back and forth. We're listening, comparing the left and the right side. So we kind of want to go starting in one area and working our way down. So you're going to go to one side, and this is where you would instruct the patient, take a deep breath in and a breath back out. I've also observed when people do this really fast, the patient has a tough time taking like deep breaths and stuff, so sometimes you may need to slow down a little bit and let the patient just be able to breathe normal rather than trying to take such deep breaths. So just here and here, and then more here and here. So actually, I'd be going here and here, and then I want to go down here to here, and I want to go down here and across to here. So then what we would want to do is we would want to listen posteriorly as well. And the same thing, you want to use, or you want to compare the sides. So you're going to start here and go here. And you want to make sure not to go too wide that you're on a bony prominence here. And here, 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 and here. So you just want to make sure that you have a good clear sound and that you can hear well. So if you would hear any of that wheezing, if you would hear anything abnormal, then you need to make sure that that gets reported. So we've inspected the chest, we palpated, we did some percussion, and we also listened to the sounds. So it is just important too that you're always assessing how the skin looks. We talked about that in the beginning, noting any abnormal findings, anything like that. So you always want to try to keep your patient covered as much as you can. And then you just kind of make sure that you document everything that you assessed. So whether you heard adventitious sounds or not, and any findings you may have. And then you just let the patient know that if they have any questions, they can let you know. And then at this time, I would go and do my documentation. Thank you.